Good morning everyone. I am Dr. Monica Shah and I'll be presenting about the basics of phacodynamics. So what does phacoemulsification consist of? It consists of the ultrasound energy which gives the power and the fluidic system for the process to occur smoothly. Now what do we look for in phaco? We look for the sculpting of the nucleus, the impaling or holding power of the phaco probe, the followability of the nuclear fragments which are created, and the chamber stability at the same time. We have a foot pedal with which we operate the machine and the probe. So the position 0 is the rest position. Then we have 3 steps. First is when the irrigation starts, second is the aspiration, the vacuum and the flow rate depends upon it, and third is the power. In higher end machines there is also a sidekick button which leads to reflux. So the aspiration flow rate is inverted, and if by mistake we aspirate any tissue like iris or PC, it is expelled. We have a phaco probe which has a transducer, converts electrical energy to mechanical energy, and it has a titanium tip, and which is silicon sleeve covers the titanium tip. It has 1 mm needle at the tip, oscillates at 40 kHz. It has a USG transducer, and lead zirconate crystals are present, which deformation of the crystal leads to the generation of energy. Now the phaco tip, there are various angulations from 0 to 45 degree. 0 has the maximum holding power and 45 has the maximum cutting power. Routinely we use 30 degree with a good holding power, because for cutting we already have the power of the machine. There is a Kalman tip present which has the angulation downwards, especially for trenching. Now how is the phaco power generated, and on what factors the power depends on? First is the stroke length, that is the maximum forward and backward movement of the probe. Usually it is between 70 to 120 micron. The frequency with which there is the movement per unit time, and so power is frequency into stroke length, and also the one which has higher acceleration generates more power. Now various mechanism with which the phacoemulsification occurs. First is the pneumatic drill effect, that is the mechanical impact between the tip and the lens material at end of each oscillation. Cavitation and implosion, it is because of the vacuum created when the tip withdraws, but the liquid and the particles cannot be returned, and this cavitation bubbles leads to implosion. Third is the acoustic wave around the tip and impact of the particles due to the forward movement of tip by each oscillation. So this is, first one is the tip at rest, second is when it shrinks there is cavitation, and if it is expands it leads to the pneumatic drill effect. There are various modes of phaco power. One is continuous, which we use in trenching. Burst mode rarely used now, but can be used for very hard cataract. Here power is fixed, eventually the gap decreases. Pulse, equal on and off time. Frequency is fixed, eventually the energy increases. Hyper pulse, more than 50 pulses per second. Surgeon or linear mode, as we increase, as we press the pedal, the power increases. There is a panel mode, transverse mode, ellipse mode. In newer machines there is also a torsional mode. So with longitudinal there is a transverse side to side angular action. For power settings, a roughly guide used for trenching is the grade of the nucleus into 15 plus 25. This is for quartz 4 to 6 crystals. So if lesser crystals, we have to increase the power. Now while coming back in trenching, we switch off the power, and if we are doing chopping, we off the power after the nucleus has been held. For phaco, aspiration reduced by 30%, and for aspiration of epinuclear sheet only 5 to 10% of power is usually needed. Now what is effective phaco time? So basically, to reduce the damage to surrounding tissue, especially corneal endothelial decompensation, we have to reduce the effective phaco time. So rather than only the duration, also it is important how it is delivered. So in trenching we are away from the cornea in a downward direction. There we have the liberty to increase the power for like the duration also and the setting also, but while careful, we have to be careful in chopping, especially if we are doing it in AC. Now this is about the power. So to counteract the heat which is generated, we need fluid around the tip. So it is to prevent the collapse of anterior chamber, also to prevent the built up heat, and also to aspirate the emulsate. Now what are the fluid dynamics? Infusion is equal to the aspiration, the fluid which comes in, and also the wound leak. So we have to maintain a stable anterior chamber, both should be balanced. So approximately 11 mm Hg pressure above atmospheric pressure is generated for every 15 cm rise of bottle above the eye level. So normally we keep it at 60 to 90 cm, maximum 100 cm. It generates around 70 to 75 mm Hg of pressure. So if we go beyond that, there is zonular stretch, discomfort, which leads to discomfort to the patient, especially if you are doing it topically. Then there are IOP fluctuation, which leads to chamber instability, meiosis of the pupil, and iris prolapse can occur from the wound. What is flow rate? So flow rate is the amount of fluid that comes out of eye per minute. So it depends upon the pump rotation, especially in peristaltic pumps. So it increased flow rate leads to a faster process. The phaco time is reduced, but also it leads to faster aspiration of the lens fragment, faster vacuum rise time, which can lead to sudden aspiration of tissues like PC or iris. So vacuum was how fast, flow rate was how fast, vacuum is how strong. So negative pressure with the pump generate, it propagates along the aspiration line, and with that the phaco probe holds the nuclear fragment. And vacuum rise time is rapidity with which the vacuum reaches the maximum following the occlusion. So with that depends our emulsification power. There are two types of pumps. One is a flow pump, that is peristaltic pump, which has rollers and cylinders. So when the tip occludes, the pressure, eventually the vacuum builds up, rollers they slow down, outflow decreases, and on complete occlusion the outflow is zero but the vacuum is maximum. Here the followability of the emulsate is less, so there is less PCR, less iris chafing, so it is better for beginners. On the other hand, we have Venturi pumps, which is a vacuum based pump, so it depends on a compressed gas, there is a gas cylinder which is compressed and generates the vacuum, depending that is based on the Bernoulli's principle. So here the vacuum and flow rate are proportionately linked. Vacuum rise time is fast, the process is faster, so it is better in hands of experienced surgeons. So followability is once the nuclear materials are broken down, how the fragments follow into the tip. So the green around the tip has good followability, so we have to make sure to bring the particles in that area. Around the yellow, the part near the green part, it has poor followability, so we try to bring the smaller fragments from periphery into the center, and grey is around the incision, which has no followability. Now there is one thing which leads to the complication is the surge. So when last piece is aspirated, now the occlusion suddenly goes and we don't have any other particle to come in. So here now the excess fluid comes in suddenly. So there is a mismatch between the fluid which comes in and the fluid which is aspirated out. So there is sudden deflation of the anterior chamber, and most probably in hands of inexperienced surgeons to start with, the PC comes into the probe and leads to posterior capsular rent. So to avoid that, first we have to understand the factors of phacodynamics which are responsible for surge. One is the compliance, that is the property of the tubing to collapse or deform under pressure. So higher the compliance, greater the surge. It depends upon the lumen size, more with larger size tubings, more at higher vacuum, and less with thicker walls. So thinner walls collapse fast. Hysteresis is speed with which the collapsed tube it regains its normal shape. So higher hysteresis, the tube comes back slower, so slowly the fluid is aspirated from anterior chamber, so surge is lesser. Now in higher newer machines, there is a vent, that is after the last particle gets sucked, a alternate vent is opened so that fluid comes from the alternate channels into the tubes, so that less fluid is aspirated from the anterior chamber. Also there is an aspiration bypass system, so there are small holes in the microshaft that is below the tube. So after complete occlusion, extra irrigation fluid is drawn through this tube to prevent surge. So basically lesser fluid flows from the anterior chamber into the tubings. Thank you. Second. Okay, I'll start. My second topic for today was the influence of corneal incision site on astigmatism after cataract surgery. It was a single center experience. We evaluated patients which we did at our center. So purpose of this study was to evaluate the effect of variation in site of clear corneal incision on surgically induced astigmatism. 3 incision sites were evaluated: temporal, superotemporal and superior. So what is SIA? Surgically induced astigmatism, it is a vector. It has both magnitude and angular direction, and both this should be kept in mind while calculating the mean SIA. So there is like a torque and flattening or steepening can occur perpendicularly. So angular will be the SIA, and depending on both of this factor will be the surgically induced astigmatism after the surgical procedure. So the astigmatism, this is the astigmatism excluding any astigmatism, corneal astigmatism which the patient already has. So this induced astigmatism is a reflection of cataract incision, then its closure and subsequent wound healing. So if there is excessive tight wound because of suturing, it induces corneal steepening in that axis. If there is any wound dehiscence or wound gap, that leads to flattening of cornea along that axis. So basically compression steepens the axis and any gapping induces a flatter cornea. Now surgical induced astigmatism depends upon various factors like the axis on which it is acting, the axis on which we take the incision, then the location, the size, so 2.2, 2.8 or 3.2 mm or higher. Gradually as the size of the incision increases, the surgically induced astigmatism also increases. The shape, there are various shapes: linear, square, rectangular. The form, how the wound is formed, like biplanar, uniplanar, biplanar, triplanar, architecture of the wound, and any pre-existing corneal astigmatism if present. So we evaluated total 90 patients in our group, in our study, and then they were divided randomly according to the location of clear corneal incision. Complete ocular examination was done, including the keratometric readings, and patients were followed up on day 30 and day 90. So inclusion criteria for my study was all the patients who were undergoing cataract surgery who consented for the study, excluding the patients who had any previous any coexisting pathology, any anterior or posterior segment surgery. Also patients with corneal astigmatism over 1.5 diopters were excluded. Then patients who required any intra-op suturing were excluded because that would change our dynamics. Now for statistical analysis, it was calculated as the postoperative astigmatism minus the pre-op astigmatism, and we didn't take the axis into consideration. So we just evaluated the amount of surgically induced astigmatism that was present, the astigmatism which was present after our stipulated 90 days period. So it was evaluated using paired t-test using SPSS 18.0 software, and it was evaluated using 5% level of significance. So and also the patients were divided into temporal, superotemporal and superior groups. Patients also were divided in that groups having with the rule astigmatism, against the rule astigmatism, and patients who showed some keratometric readings but did not accept any any cylindrical power. So this was to evaluate if the patients with the rule, against the rule, who had better the correction index was higher in same in both, or it was different for both the astigmatism. So results of surgically induced astigmatism on day 30 were compared to day 90. So for temporal it was 0.83 reduced to 0.76. For superotemporal it was 0.92 which was reduced to around 0.89, and superior was 1.19 reduced to 1.01. So for like at the end of the study, we concluded that temporal group surgically induced astigmatism was lesser in the temporal group as compared to the superior and superiotemporal group. It gives better visual outcome, good optical quality and better patient satisfaction. Also, the correction index was higher for against the rule patient as compared to with the rule, because we especially in temporal incision, because the incision was given at its steeper axis. So to compare the two incisions, comparing the temporal and the superior incision. Now temporal incision, the distance between the corneal apex, that is our visual axis, and entry point is higher. So it any change at that axis, the comparative change there forms a lesser, creates lesser impact as compared to the if incision is taken at a superior site where it is nearer to the limbus, and also near superior limbus where it is nearer to the central visual axis. The temporal incision, if we have to choose between two and we evaluate it according to the patient, so it is recommended for patients with against the rule astigmatism, where for superior incision we take patients, it is better for with the rule astigmatism with steeper axis at 90 degree. Also the ease of operation and more accessible is our temporal incision. The limitations of our study were that it did not reflect the true corneal astigmatism, as the AR machine takes into consideration the total astigmatic power of the eye. Also, it does not consider the posterior corneal surface. Thank you.
Thank you so much, Dr. Monica Shah, for a wonderful presentation. And you made basic of phacodynamics very easy, and your corneal incision was very good. So I would like to present now Sonia Jagtap. She'll be talking about SICS in complicated cataract, followed by surgical outcome of iris claw lens in complicated cataract surgery.
Good morning, everyone. Good morning, everyone. I would like to thank AIOC for giving this wonderful opportunity. My today's both the topics are very simple, yet they are very important regarding the surgical outcome. My first topic is manual small incision cataract surgery in complicated cataract situations. So in the era of femtosecond cataract surgeries, why should we learn and master small incision cataract extraction surgeries? Because there are many good reasons. First of all is it provides affordable cataract surgical care. It is a plan B in difficult cataract situations like hard cataracts and low corneal endothelial cell counts, as well as whenever there is a subluxation more than 180 degrees. It has a wider applicability, it is more safe, and it has a shorter learning curve. It gives reliable and comparable results to phacoemulsification. It does not require any expensive instrumentation and can be performed in high volume eye cams with good surgical outcome. So before taking an incision, we should take into account detailed history, especially in cases of presenile cataracts where patients might have history of trauma, or there can be systemic illnesses like diabetes. Best corrected visual acuity as well as pinhole vision is important to know the possible visual outcome. Surgical slit lamp examinations, including both the anterior and the posterior segments, are important to examine, as well as the lids and adnexa. Intraocular pressure should be checked. It is very important to counsel the patient and customize surgical planning. Now I'll be discussing different cataract situations and the challenges that we come across and how to overcome those challenges. First is the deep socket eyeball. Here the challenge is the surgical manipulations because we have limited access. Key step here is the eyeball elevation with peribulbar block. The important step is superior rectus bridal suture. If we do not take it properly, there is high chance of premature entry and delivering of the nucleus becomes very difficult. And temporal incision, especially in cases of left eyes where the nasal bridge come across while taking the side port. The next scenario is a traumatic cataract. Challenge here is the capsular bag instability. The posterior capsular status is unknown in these cases. Anterior capsular wrinkling can be there in very old traumatic cases like this picture. Here the key steps is the rhexis with Utrata forces because it gives a very controlled rhexis. Minimal hydrodissection and nucleus manipulations might save our back. CTR iris claw standby should be there and VR backup should be there. Now the third case scenario is brown cataract and a black cataract, that is cataracta nigra. Here the challenges are the large rhexis. While doing the rhexis, there is a chance of running out of the rhexis and a nucleus delivery. So the key steps here are the large scleral incision, large CCC using dye. We should keep dye for a longer time. Soft cell technique to protect the corneal endothelium during nucleus delivery, and we should take sutures to reduce the astigmatism. In cases of hypermature or intumescent cataracts, the challenge is the CCC extension and there could be a chance of phacodynamic. So we should do a slit lamp examination beforehand to see whether there is actual phacodynamic or not. Key steps here is the envelope CCC. We should debulk the nucleus. We should remove the liquefied cortex with using 26 gauge cannula, or we can also use Simcoe cannula. And we should have standby CTR and iris claw lenses in these patients. Lens-induced glaucoma, the challenge is raised intraocular pressure, corneal edema. There is poor visibility and there could be inflammation and phacodynamic due to poor capsular support. Here the key steps, we should counsel the patient for the guarded visual prognosis. Pre-operative intraocular pressure reduction is very important, as well as the inflammation control by pre-operative steroids. For phacomorphic glaucoma, blind CCC and nucleus debulking, as well as we should avoid hydrodissection. And phacolytic glaucoma, the control CCC should be done with the Utrata forceps because there is no cortical support. In cases of PXF cataract, the challenge here is the poor pupillary dilatation and zonular weakness. There can also be the raised intraocular pressure. Key steps here are the careful CCC because we have to do blind CCC, gentle and generous hydrodissection to be done. Cortex aspiration is also blind. CTR and iris claw are very important. We should keep them standby, and vitrectomy cutter should be there. So in cases of non-dilating pupil, it can be managed in the similar manner as that of PXF cataracts. Posterior polar cataracts, here there is a chance of posterior capsular rupture during hydrodissection. So we should counsel patient regarding the secondary IOL. We should do small CCC because these cataracts in the central and these cataracts normally are soft. Hydrodelineation, that is the golden ring sign, should be done instead of hydrodissection. We should maintain intra-ACE pressure with the cohesive viscoelastic. In case of PC dehiscence, we should tamponade the PC with the cohesive viscoelastic, dry aspiration of cortex, and then implant the three-piece IOL in the sulcus or in the back. Complicated cataracts or uveitic cataracts, the challenge here is the festoon pupil and post-operative inflammation. Here we should see that the eye should be quiet at least for 3 months before surgery, and surgery should be done under steroid cover. Here peeling of the membrane is important, synecholysis should be done to do good CCC, and patient counseling for the long-term steroids. Cataracts with compromised cornea, here the challenge is poor visibility and we have to perform blind CCC. PC tear can be there because visibility is very poor. So here we have to again counsel the patient for guarded visual prognosis. To improve the contrast, we should keep the dye for longer time. And in cases of cataracts with poor endothelial count, here the challenge is post-operative corneal edema. So we should actually counsel the patient for, they might need maybe corneal transplant surgery. The key step is patient counseling, then soft shell techniques should be used, and smooth nucleus delivery should be taken into account, and minimal manipulation should be done to reduce corneal edema after surgery. Now my take-home message is to customize and customized surgical planning. We should counsel patient beforehand. We should always check pre-op list, checklist, and we should prepare for the surprises, and we should be safe. And thank you. My next talk is can we go back to the first slide? Yeah. My first, next talk is surgical outcome of the iris claw lens in complicated cataracts. Now, how should we deal with the PCR in cases of manual small incision cataract surgery? So we should first see whether there is real PCR or not. Whenever we are in dilemma, we should confirm it with the triamcinolone acetonide injection into the intracameral site. If there is a PCR, then we should look for the status of the nucleus. If there is a nucleus drop, then we should suture the wound, counsel the patient and refer it to the VR surgeon. If the nucleus is intact, then gentle viscoexpression of the nucleus is to be done. After that, we have to analyze the size and the location of the PCR. Then we can we should tamponade the PC tear with cohesive viscoelastic, cortex aspiration, and anterior vitrectomy is to be done. Then we should analyze the sulcus if it is intact or it is compromised. Now, now we have to analyze the situation aphakia with the open posterior capsule. So if the sulcus is intact, then we can go ahead and implant the 3-piece IOL and do optic capture if possible. If there is the anterior capsular rim is not intact, then there are 4 options. We can implant a 3-piece IOL, but there are chances of subluxation or dislocation. We can also fix iris claw lenses. We can implant AC IOL, and scleral fixation is also an option. Now, how to decide which lens to be implanted in cases of compromised sulcus? So we should see whether the patient has good visual outcome, with good potential of the visual acuity, and whether patient can tolerate spectacles and contact lens. If the patient has normal iris, then we can go ahead and implant retropupillary iris claw lens. In these patients, it is important to do regular follow-ups. Then if the iris is absent or it is damaged, then we can go ahead and implant scleral sutured IOLs with Prolene 9O suture, and iris reconstructions can be done. If patient has any uveitis, uncontrolled glaucoma, inability to follow up, then surgeries are contraindication in these patients. Why should we choose retropupillary iris claw lenses? Because technically they are very less challenging. There is short learning curve. It protects corneal endothelial cells, protects iridocorneal angle, and the secondary glaucoma is very less likely, and the rate of dislocation is less. Now, what are the possible complications with the retropupillary iris claw lenses? There are iris chaffing and chronic inflammation can be there. Pupillary distortion, sigmoid macular edema, poor dilatation of the pupil can occur after implantation. So before implanting iris claw lens, we should make sure that there is no vitreous in the pupillary plane. We should stain it with the triamcinolone acetonide. IOL power is to be adjusted before implanting. Then optic is well centralized. Both the haptics should be fixed, and peripheral iridectomy should be done at the last. So how to implant retropupillary iris claw lens? We have to make one side port opposite to the previous side port. We have to inject pilocarpine in the anterior chamber and align the optic centrally, then tuck one haptic, then tuck other haptic in the same plane. At the last, we should do peripheral iridectomy. Now we conducted one study of surgical outcome of the retropupillary iris claw lens in manual small incision cataract surgery. The purpose was to analyze the visual outcome and complications following retropupillary fixated iris claw intraocular lenses. So it was a retrospective study, non-comparative. We reviewed 74 patients who underwent primary retropupillary iris claw implantation for correction of the surgical aphakia. It was conducted during the period of December 2021 to 2023, and it had a minimum post-operative. We followed up for 2 months, and we checked post-operative best corrected visual acuity and intraocular pressures, and complications were noted. So these were our results. We saw 86.48% of patients showing more than 6/9 visual acuity, and only two patients had almost 3% of visual acuity less than 6/60. 3 patients developed secondary glaucoma. 4 patients had cystoid macular edema. 5 patients had to undergo resurgery for one optic subluxation. All patients had good pupillary dilatation. Only 1 patient had corneal decompensation, and 1 patient had retinal detachment. So this was the patient with 1 haptic dislocation. We had to do resurgery for this patient. This was the commonest complication we encountered. Finally, the conclusion. So I would like to conclude with the retropupillary iris claw IOL provides good visual rehabilitation with fewer complications. Ease of insertion and short surgical time makes it a good option to correct aphakia in patients with inadequate capsular support. And thank you.
Thank you so much, Dr. Sonia, for a wonderful presentation. The complicated cataract you have made very easy. So, we'll be taking questions in the end of the session. I would like to ask Dr. Kanchanwala Rathod to present a clinical and surgical profile of cataract surgery in pseudo-exfoliation eyes. And the second topic of her is surgery for posterior lentiginous cataract.
Good morning, everybody. So I will be presenting on the clinical and surgical profile of cataract surgery in pseudo-exfoliation eyes. So there is something known as true exfoliation also. True exfoliation is basically de-lamination of the entire capsule and usually seen in glass blowers, blacksmith and steel workers. But we are going to discuss about pseudo-exfoliation. So pseudo-exfoliation involves deposition of fibrogranular material on numerous lens structures like lens capsules, zonules, iris and ciliary body. So as I have already described, it is a systemic condition characterized by the accumulation of extracellular fibrillar material. So epidemiologically, if we see, it is approximately affecting 10 to 20% of patients more than 60 years of age, basically in tropical countries. So why the pseudo-exfoliation in cataract is important? Because there are many surgical challenges which increases in case of pseudo-exfoliation eyes. So what are those? First is the poor pupillary dilatation. Second, zonular weakness. There is an increased risk of lens dislocation. Post-operative intraocular pressure rise. So we have to devise some surgical strategies to how to deal with such cases. So when we see the clinical profile, so first is we will see a pseudo-exfoliation deposits on lens, or you can see even on the zonules. The second, pupil, non-dilating pupil. So we may need an extra mydriatic or some like mechanical dilatation during surgery. Third, we can encounter zonular instability and phacodynamic. So a lot of intraocular complications. It is also observed the cataract in pseudo-exfoliation is more dense as compared to normal population. There is a significant risk of glaucoma also. So now pseudo-exfoliation with glaucoma. Glaucoma is already like a extra surgical risk to manage. So what about the preoperative evaluation? So a comprehensive ophthalmic examination should be done. A slit lamp examination should be done. Examination of the pupil, size of the pupil, what is the zonules status, whether phacodynamic is there, then what is the pressure, intraocular pressure of the patient. So because this will help in the preoperative counseling and will help in the reduction in the potential complication which can happen intraoperative, plus a post-operative patient satisfaction will increase. So what are the strategies for pupil management? What can we do? So first is pharmacological strategies. So usually we give a mydriatic, we can use tropicamide, cyclopentolate, hometropine, preoperative tropine iointment, intracameral mydriatic, or a subconjunctival injection of a midricane, or a topical non-steroidal anti-inflammatory drug such as flurbiprofen. So it will augment the dilatation as well as maintain the intraoperative mydriasis. Suppose the pharmacological strategy doesn't work, so what we can do? Then comes the pupillary stretching. So we require a bimanual stretching of the pupil. Any two instruments can work, either a Sinskey hook, a blunt chopper, a Y hook, Coughlin hook. So we have to stretch the pupil in the opposite direction, either one from the side port and one from the main port. So it can give a considerable dilatation of the pupil. The only problem is, like if we damage the iris, we can have a hyphema or an intraoperative bleed at that time. So what are the other devices? We can use an iris hook, we can use a dilator or Maillon ring. These are the two commonest things, iris hooks and a Maillon ring. But then they increase the surgical time. So suppose there is a patient with a small pupil with pseudo-exfoliation. We gave a mydriatic or we did a viscodilation. If the adequate dilatation is there, we can progress with the surgery. But suppose there is no dilatation. So we will analyze the adhesions, pupillary adhesions. If there are adhesions, then we will break the adhesions. Suppose there is a dilatation is there, we can progress. But if there is no pupillary dilatation, we can go with the mechanical stretching, or we can use expansion devices. So this is about the pupillary dilatation. Now about the capsule rhexis. Again, there is a deposition of pseudo-exfoliating material on the capsule. So the capsule rhexis is not going to be as smooth as the normal patients. So what difficulties we can face? We can face initial puncture become difficult, or when we are doing the rhexis, there will be stria. So whenever there is stria formation, we should have a mind there can be some zonular weakness in the patient. Zonular weakness can be such that we have to give a counter traction with the other instrument to continue the rhexis. So ultimately, these are the difficulties we can face during the rhexis in pseudoexfoliation. Hydrodissection. Now hydrodissection should be in such a manner that it causes minimal stress on the zonules. So multi-quadrant cortical cleaving hydrodissection is recommended. So this can help even in the rotation and proper removal of the nucleus from the cortex. It can also help in the augmentation of the CTR insertion, because most of the pseudoexfoliation patient will have some or the other in some quadrant zonular weakness. So CTR insertion also helps. So what about the phacoemulsification settings? So we have to reduce the phaco power. So entire process has to be slow. So all the parameters has to be low. Capsular tension rings should be used SOS basis. If required, if there is a marked, like if there is a 3-quadrant to 4-quadrant zonular weakness, we can put a CTR. Then appropriate recognition and management of zonular dialysis, vitreous loss and capsular rupture should be managed. Already iris claw and lens has been discussed. So such cases with marked zonular dialysis, we can use iris claw lens. Okay. Then comes a post-operative. Since iris handling is much more, there is more chances of post-operative inflammation. So we must focus on the IOP control as well as the inflammation management in the post-operative cases. So if the pre-operative evaluation, intraoperative management can definitely help in the good post-operative outcome with proper selection of IOL lenses. So we have already discussed what are surgical challenges: poor pupillary dilatation, zonular weakness, chance of PC rupture, chance of zonular dialysis. So like there are many advancements which are coming in the surgical techniques as well as instrumentation, which are helping in the proper management of such cases. Thank you. So my next topic is lenticonus, cataract surgery in lenticonus. That is posterior lenticonus. So what is posterior lenticonus? The lens is cone shaped in the posterior side. So it is definitely a congenital anomaly. So if we define it, it involves a bulging of posterior lens capsule and cortical matter into a cone shaped, which can progressively ossify, forming a cataract. The condition is unilateral in most cases and is often present in the childhood. So again, the chances of amblyopia increase in the childhood. So the lenticonus, the cases of lenticonus have a combination of pediatric cataract as well as posterior polar cataract. So both the cases are unique cases, the posterior polar cataract as well as pediatric cataract. So this becomes a very like a more important combination where we have to deal with the cases, such cases. So several theories has been proposed to the development of posterior lenticonus, which may include subepithelial capsular hyperplasia, embryologic hyalidatory traction, inherent weakness of the PC wall. So basically, what main surgical issue is with the PC weakening of the posterior capsule. This is what we have to deal. So a case of lenticonus may present in such form, either a plain lenticonus or there is a cataract formation in the posterior capsule or a lamellar formation, or there can be a complete cataract. So cataract associated with posterior lenticonus typically progress more rapidly than age-related cataracts and is usually seen in the pediatric cases, so it necessitates early surgical intervention. So what is the main challenge? Main challenge is the posterior capsule thinning. So there is already a pre-existing weakness. So what surgical strategies we can do? So first, pre-operative evaluation has to be done properly. Now what we can do? we can see the integrity of the posterior capsule by ultrasound, or we can see with the OCT, anterior segment OCT, what is the status of the posterior capsule. So this can help in the intraoperative planning of such cases. So a precise, now coming to the capsular rhexis, since in the pediatric cataract the rhexis running off is the main issue, so we can use a more viscous viscoelastic. We can make controlled and precise anterior capsular rhexis by grasping, re-grasping and inward pull technique. Hydrodissection, hydrodelineation should be performed with extreme caution, again because of the weakness in the posterior capsule. A low flow, low energy phacoemulsification settings has to be used to minimize zonular and capsular stress. So these modification, intraoperative modification when we encounter such cases. Now the surgical management in case of total cataract in posterior lenticonus. Now usually when we approach, we go into the periphery, but in a total cataract there is a risk that there can be a central drop of the nucleus chunk or the liquefied material, since there is a liquefied material. So in some of the, we can just, this biscuit in chai, like when we dip, the center biscuit can drop inside. So that we have to deal. So we have to approach the center portion first, then we have to go to the periphery to avoid such conditions, such like incidents. There has been also described a pars plana lensectomy, vitrectomy and posterior chamber intraocular lens insertion into ciliary sulcus with central anterior capsulotomy. So a pars plana approach has been also been described for the lenticonus. So like IOL selection depend upon the posterior capsular status. Even a scleral fixated or a PCIL in sulcus with optic capture, this can be done for such patients. Then vitreous loss has to be managed more aggressively in such patients, since they are young patients. So there will be a more vitreous loss. Again, the post-operative care should focus on the inflammation control, prevention of amblyopia in patient, and monitoring visual axis opacification, which is more common in, as I have told, it is a combination of posterior polar and pediatric cataract. So both the strategies we have to combine to manage such cases. So with careful surgical planning and proper intraoperative modification, we can give a very good outcome and we can prevent amblyopia in pediatric cases. Thank you.
Thank you, Dr. Kanchan, for a wonderful presentation and such an informative session. Now I'd like to welcome Dr. Arundhati Pandey. She would be discussing two very rare and two beautifully managed cases of aniridia and Sturge-Weber syndrome.
Hi, good morning all. So my topic of presentation is Sturge-Weber syndrome. I am Dr. Arundhati Pandey. I am working as a head of department and professor at Symbiosis Medical College for Women at Pune, Maharashtra. So what is Sturge-Weber syndrome? It is a neurological condition, a rare neurocutaneous disorder characterized by abnormal blood vessel development in the skin and brain. There is a blood vessel malformation condition marked by a port wine stain, birthmark and abnormal blood vessel in the brain, which can lead to neurological symptoms. Impact on development. It can cause neurological impairment and developmental delays due to structural brain abnormalities associated with the syndrome. So what are the symptoms and manifestations? Seizures. Seizure is very common symptom, often starting in infancy and can be resistant to medication. Glaucoma and eye issues. Glaucoma occurs in about 30 to 70% of patients and can lead to vision loss, while other eye problem may be also present. And it is associated with cognitive impairment, including developmental delays and intellectual disability. So we had a 19-year-old male presented in ophthalmology OPD with a diminution of vision in the left eye. So we have investigated him in detail. So he had port wine stain, left eye no perception of light, enlarged cornea, Marcus gun pupil, glaucomatous optic atrophy. These were the perimetry changes. His right eye was absolutely normal, but if you can make out, there is a left eye, the whole visual field changes were there and the optic atrophy was set in. This patient was on the anti-epileptic drug like carbamazepine, so he had raised serum alkaline phosphatase. So X-ray skull showed Frontal sinuses, they were prominent, and 3 tiny intracranial calcification opacities also were seen. CT scan, linear calcification in the parieto-occipital region, prominent vessels in the bilateral high parietal and left parieto-occipital region, enlarged left choroidal plexus. His MRI also done, so it showed enhanced choroidal plexus, gyral calcification in parietal region, prominent frontal sinus. Now this patient we sent for a pulse dye laser photocoagulation because for his left eye, and we asked the patient to come for a follow-up very regularly every 6 months for his right eye. Now the basic of what is Sturge-Weber syndrome? It is a port-wine stain, ipsilateral leptomeningeal angioma. It is associated with glaucoma, then diffuse choroidal hemangioma, seizures and focal neurological deficit, biphthalmos. If the child is presenting in the early age, they present with a biphthalmos. Intellectual disability, it is not inherited due to somatic mutation. And the brain MRI with gadolinium contrast is very important, and it shows a time track calcification. So when we go for the history of the Sturge-Weber syndrome, it is also known as a encephalotrigeminal angiomatosis because that is the course, and is a congenital neurooculocutaneous syndrome. It was first reported by Dr. Sharma in 1860 with later description by Dr. Sturge in 1897 and Dr. Weber in 1922. That is why it is a Sturge-Weber syndrome. It has a sporadic developmental disorder caused by somatic mosaic mutation in the GNAQ gene, which is located on long arm of the chromosome 9. It is not hereditary. The incidence has been reported to be 1 per 50,000 live births. So it is a neurocutaneous disorder characterized by angiomas involving face, choroid and leptomeninges. The facial capillary vascular malformation, also known as port-wine stain or nevus flammus, is usually seen in the territory of a trigeminal nerve. It is also called as a encephalotrigeminal angiomatosis, and it is the third most common neurocutaneous syndrome after neurofibromatosis and tuberous sclerosis. The neurological manifestation of SWS include atonic, tonic or myoclonic seizures. So it includes the meninges, and this is the distribution of the trigeminal nerve. So we will see port-wine stain in this area. Again, port-wine stain, there are various presentations. This is a picture showing all the different presentations. So this is the Sturge-Weber syndrome. We see the calcification in these areas. So what is the treatment and management? So the first important is life. So we have to manage, seizure management is very important. Medication are commonly used to control seizures, while some may benefit from surgical intervention. Physical and occupational therapy. Therapies aim to address physical and cognitive challenges, improving independence and quality of life. Laser and glaucoma therapies, they are must, though it is refractory to all the medical management. So we have to do the role of surgery is very important. And the preservation of vision is very important. Then educational support is must for this patient, and psychological counseling because of the treatment and the long-term treatment they may face psychological problems. And we have to give supportive devices like mobility aids and communication tools which promote independence and participation in daily activities. So to conclude, quality of life is very important while managing the challenges associated with Sturge-Weber syndrome. Family support is very important, and some research is still going on. So thank you so much for your patience. So now my next topic is familial aniridia with bilateral developmental cataract with macular hypoplasia. So I'll be talking about aniridia and with macular hypoplasia. So why this topic is chosen, why I chose this topic. So aniridia is a rare genetic condition of the eye in which there is a partial or complete absence of iris. It is associated with fragile capsule, hypoplastic iris and glaucoma, making it complicated case for cataract surgery. Surgeons are reluctant to operate such cases because they are prone for the more complications. The purpose of this case study is to discuss strong genetic link in aniridia patient, validate the fact of it is a rare condition. Emphasis on need to operate patient for cataract surgery. So we had a 13-year-old female presented. She residing at Barshi, Maharashtra. It is presented in ophthalmology OPD with a history of brain PPG DOV since 1 year. Her loss of vision in the right eye was more than left eye. She had photophobia for 7 years. On the clinical examination, she had complete aniridia in both her eyes, and there was a developmental cataract in both her eyes. So we did the further investigations, and her IOL scan was a 29.5 in the right eye and 29 diopter in her left eye. So a detailed ocular history, then slit lamp examination, gonioscopy, fundus examination, intraocular pressure and a B scan was done. USG abdomen also carried out for urogenital abnormalities. Decided to do a phaco with a foldable IOL under local anesthesia of the right eye first, and all the steps were done nicely. Then after putting the lens, the wound was closed and she had post-op vision 6/12 unaided. So if you can make out, there is a complete aniridia. This is a right eye cataract, the left eye early cataract. After post-operatively, day 1 we put the air bubble and okay. Now this is her mother. She had both eye pseudophakia, and her mother is operated at the age of 20 years. So vision increased from finger counting close to face to 6/12 and 2-line visual impairment due to macular hypoplasia. So to conclude, a detailed history, ocular and systemic investigation in family members of aniridia patient is strongly recommended. Aniridia patient, they can have a normal vision post cataract surgery with a special care, and there is no financial disclosure. So what is aniridia? It has cataract, glaucoma and the corneal abnormalities. Vast majority cases they occur isolated without systemic involvement due to deletion of paired box gene 6, that is PX6. It can also occur in minority of cases as a part of WAGR, that is Wilms tumor, aniridia, genital abnormalities and mental retardation. It is sometimes due to adjacent PX6 or the Wilms tumor gene if they are both deleted. Individuals with WAGR have a significant risk of developing Wilms tumor and childhood kidney malignancy. The prevalence of aniridia is 1 in 40,000 to 1 in 1 lakh. So what are the phenotypes? Isolated aniridia without systemic involvement, WAGR syndrome and Gillespie syndrome. They come up with the various and different presentations. So aniridia type 1, that is 85%, and it is familial aniridia, autosomal dominant with incomplete penetrance and expression, and it is they come out as an isolated ocular defect also. So aniridia type 2, that is a 13% Miller syndrome. It is sporadic, non-familial aniridia and Wilms tumor, deletion or mutation in short arm of chromosome 11. It is associated with Wilms tumor, genitourinary abnormalities and mental retardation. Craniofacial dysmorphism. Then aniridia type 2, it is autosomal recessive aniridia, mental retardation, cerebellar ataxia, structural defects in the cerebellum and brain, and it do not develop Wilms tumor. So I would like to say thank you to everyone for your patience, and if you have any doubts or questions, we are open to, you are free to ask. Yeah, so we conclude our session, and thank you so much for your patience.